lung volumes and the capacities. So what is lung volumes and capacities? This is one of the important laboratory parameter which we will always order as lung function test. That you call as spirometry. So spirometry is the instrument which is used to measure the lung volumes and the capacities. Okay. So can you all tell me what are all the lung volumes, capacities? Residual volume, tidal volume, inspiratory reserve volume, expiratory reserve volume. And what are all the lung capacities? Okay. So we have 4 lung volumes and 4 lung capacities. So this is the spirometer which is used to measure the lung volumes and capacities. Okay. So this is the arrangement of the spirometer. No need to know in detail how the spirometry is working. Just consider this part. Please stop talking. So just consider this part. So this is the part where it is connected to the lever and the pulley mechanism. So which is connected to the end of the edge of the pen. And this pen is in connection with the drum. This is the rotating drum. Okay. So what happens when the person is inspiring? This drum will come down. When this drum is coming down, the pen which is in connection with this will goes up and it will draw the graph like this. Okay. So first, during inspiration, what happens? The air is going inside. Okay. This is during the recording process. Okay. The air is going inside. And the drum which is in connection with this is also connected to the pen. And this pen is over here and this is the rotating drum. This drum keeps on rotating. When the inspiration is taking place, the air is going over here. So the drum is coming down, making the pen to move upwards. And you will get the upward positive wave, that is during inspiration. And followed by expiration. If the person is exhaling the air, then what happens? The drum goes up and the movement of pen is downward direction and you will get the graph like this. If a person is having rhythmic respiration, the graphical recording in the spirometry will be like this. Okay. So this is during normal breathing. Instead of normal breathing, if a person is performing forced inspiration, then what will happen? The pen will move still more upwards direction. Yes or no? And followed by forced inspiration, you will get forced expiration. In order to get the excess amount of air which is inspired during forced inspiration, you have to exhale the excessive air too during expiration. So this expiration will come like this. So this is what you are getting in this graphical representation of the spirogram. Now we are going to give the names, different names which is constituting the lung volumes and the capacities. Okay, clear? So now you know why the graph is like this and why in some places graph is going like this, coming like this, because of forced breathing, normal breathing. In normal breathing, you will get the graph within the limit, normal rhythmic respiration. In case of forced breathing, because of excessive amount of air going, it is working in this way. Okay. In detail about how the spirogram works, that and all we don't want to know. So now, what is this limit? This is the limit mentioning normal breathing. And this is the limit mentioning forced breathing. Okay, clear? And now, first one what we are going to see is the tidal volume. So what is meant by tidal volume? That is the graphical representation within this limit. This limit is for normal breathing. So what will be the definition of tidal volume? That is the volume of air which is inspired and expired during normal quiet breathing. Okay, clear? So that is the volume of air which is inspired and expired during normal quiet breathing. And now you are doing forced inspiration. So in the sense, excess of air is entering into the lungs more than the level of normal level. So the normal level you can also tell as tidal volume level. Yes or no? So that is going to give you the definition for inspiratory reserve volume. So it is the volume of air which is inspired more than that of the tidal volume level, because tidal volume is within the normal limit. So more than that of the tidal volume level, if you are doing the inspiration, so it means the volume of air which is entering into the lungs more than that of the tidal volume level, that is inspiratory reserve volume. And so the graph is running up to this forced breathing level. Followed by this, you are having forced expiration. So from up to this level, it is normal. So beyond that, it is beyond the normal level. So you will define expiratory reserve volume as the volume of air which is expired more than that of the tidal volume level, or the volume of air which is expired beyond the tidal volume level. Okay, so now you know there are 4 lung volumes: tidal volume, inspiratory reserve volume, expiratory reserve volume. If you know why this graph is coming, how this graph is coming, you can easily tell the definitions of these. And one more lung volume is there, that is called as residual volume. This residual volume, as the name residue, what is the meaning of residue? The amount of air which is always remaining as a residue in the lungs, which will not take part in any kind of breathing, whether it is normal breathing or forced breathing. So this residual volume is one of the factors which is helping in preventing the collapse of the lung after expiration. So we have seen 2 factors already. The respiratory pressures. There is pressure inside the lungs, outside the lungs, which is both acting in different directions at equal strength. So which prevents the lungs from the collapse. And another thing is intrathoracic pressure, which is preventing the collapse of the lungs. And this is the 3rd factor. The residual volume is one more factor, that is the amount of air always remains in the lungs, which will never be expired. So this volume of air is called as residual volume. This residual volume cannot be measured with the help of spirometry, because the pen is moving up and down to the amount of air which you are inspiring and expiring. But this residual volume is remaining as a residue in the lungs. So this cannot be measured with the help of spirometry. For this, you need a special type of method called as nitrogen washout method. The residual volume is measured by nitrogen washout method. Remember this always, residual volume cannot be measured by the spirometry. Okay, because the spirometry is measuring only the graphical representation given by the movement of the pen. Okay, that is how the measurement is happening in the spirometry. This residual volume is not involved in inspiration or expiration, whether it is normally or during forcedly. Okay, so this is one of the important thing you have to remember, residual volume cannot be measured with the help of spirometry. Okay, and now we are going to see, we have seen already 4 lung volumes, and from those 4 lung volumes we are going to see the lung capacities. So now you are the one going to tell me the lung capacities. What is this? Tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume. These are the lung volumes. So now, what you call as the combination of all these 3? Vital capacity. Okay, so vital capacity is the combination of tidal volume, inspiratory reserve volume and expiratory reserve volume. Now, how will you define vital capacity? That is the volume of air which is involved during forced respiration, because tidal volume includes normal breathing. Inspiratory reserve volume includes forced inspiration, and expiratory reserve volume includes forced expiration. So, the volume of air which is present in the lungs during forced breathing, it is called as vital capacity. That is the maximum amount of air which the lung can hold in forced breathing. Okay, clear? That is vital capacity. And now, tidal volume plus inspiratory reserve volume. How will you call it as? Inspiratory capacity. That is the maximum volume of air which can be inspired. That is called as inspiratory capacity. And functional residual capacity. That is volume of air which remains in the lungs after the normal breathing. Expiratory reserve volume is forced breathing. Residual volume never involved in forced breathing also. So, this two will give you the functional residual capacity. Okay, and the combination of all the 4 is the total lung capacity. Okay, so this is how you will define the lung volumes and the capacities. Functional residual capacity, that is the volume of air which remains as a residue in the lungs and it will not involve in, which remains as a residue in the lungs and it will not involve in normal breathing. Residual volume is different. Residual volume is the volume of air which remains as a residue even after forced breathing. Functional residual capacity includes the expiratory reserve volume. Expiratory reserve volume is the volume of air which is expired beyond the tidal volume level. So, functional residual capacity includes the volume of air which is expired beyond the tidal volume plus the residual volume. Understood? Okay. So, this is what is the spirogram and its values. Lung volume and capacity is clear? Yes, you will get questions from these lung volumes and capacities. First, you should define what is lung volume, what are all the lung volumes, how the lung volume is formed. If you understand the spirogram, how the measurement it is taking, you can easily remember. And you will get the questions related to the lung capacities. Which 2 volume combining and forming the lung capacities. So that scenario you should always remember. Okay. And related to that, we will see a case. A 65-year-old male who always use 75 pack year smoking history. And he is presenting to the pulmonologist for the evaluation of dyspnea and exercise intolerance. What is meant by exercise intolerance? The person was feeling difficulty in breathing when he is doing exercise. And what value does the pulmonologist expect to see in the pulmonary function test? Pulmonary function test will give you the value of lung volume and the capacities. So during exercise, what kind of breathing you will encounter? Is it normal breathing or forced breathing? Forced breathing. So during exercise, the vital capacity increases. So vital capacity is the combination of tidal volume, inspiratory reserve volume plus expiratory reserve volume. So you will see the vital capacity. Vital capacity will be increased normally during exercise. But this person is having dyspnea and exercise intolerance. Then what will happen to the value of pulmonary function test in this case? Whether it will be increase or decrease? Why? Why? That is what? Why he was unable to do the forced breathing? So what? If a person is an athlete and becoming old, was he not able to do the function? Yes, he is having a higher family smoking history of how much? 75 packs per year. And he is almost 65 years old. It means how long he will be having the smoking history? More than 10 years, 15 years? We cannot determine. If the person is 65 years old and he is having a smoking history of 75 years, 75 pack per year means almost he might be having it from the adulthood period. Okay, so there is excessive amount of damage already present in your pulmonary system. And that is the reason why, even though if the person is not doing exercise, maybe he will feel dyspnea. And since the higher positive history of smoking and makes the pulmonary functions not to happen properly, there is more accumulation of you can encounter constriction of the airways. So that decreases the amount of air entering and going out of the lungs. Okay, so the vital capacity value will be decreased in this case. Okay, clear? So this is how you have to use the pulmonary function test in your diagnosis. Okay, clear? And there is another factor called as timed vital capacity. So in generally we have seen what is volumes, what is capacities. And this is timed vital capacity. This is the measure of vital capacity with respect to the time. What is the normal respiratory rate per minute? 12 to 15 breaths per minute. Okay. So, okay. And one more factor we will see in the pulmonary function test is the timed vital capacity. So this timed vital capacity will be seen when there is a differences, when there is a respiratory differences, when you have some respiratory abnormality. And if you want to differentiate whether the abnormality is due to obstructive lung disease or due to restrictive lung diseases, like COPD, and due to not audible? Audible? So when you want to do the differentiation between the obstructive and restrictive lung diseases, you will do this timed vital capacity. This timed vital capacity is the measure of vital capacity in relation to the time. So usually this timed vital capacity will be measured with respect to the time in the representation at the end of 1 second, at the end of 2 seconds, at the end of 3 seconds, like that. Okay. In relation to the time, you will give the value as FeV1. This one indicates at the end of 1 second. If it is FeV2, that is at the end of 2 seconds. And how will you calculate the value in this timed vital capacity? Is the volume of air expired at the end of 1 second multiplied by 100 and divided by the normal vital capacity. So usually you will get the forced expiratory. This FeV1 is forced expiratory volume. Okay. So this will be normally of 80%. Since you are multiplying it with 100, you will represent the value in percentage. So if it is more than or equal to 80%, if it is less than 80%, most probably in restrictive lung diseases, it will be more than or equal to 80%. And it will be less than 80% in case of obstructive lung diseases. So that is how you will differentiate based on the pulmonary function test whether the defect is due to restrictive or obstructive lung diseases. This is one investigation parameter. Okay. And apart from this, based on the symptoms, you have to further do the further investigations to rule out the specific cause of the disease. Okay. So this is just the differentiation tool to find between obstructive and restrictive lung diseases. Only that you can do with this. But you cannot find the exact mechanism causing the obstruction or restriction, whatever it is. Okay, clear? So there is one more case. A 60 years old heavy smoker again presents to the clinician with long-standing shortness of breath. So the person is experiencing long-standing shortness of breath upon exertion. So when he is doing some heavy works on exertion, he is experiencing long-standing shortness of breath. And she is diagnosed with emphysema. What is emphysema? Destruction in the walls of the alveoli. So the alveolar wall is destructed. This is how it should be normally. And if the alveoli wall is destructed, the gas exchange will not take place properly. And destruction in the wall of alveoli is damage in emphysema. In which category you will bring this disease? Obstructive disease or restrictive? So now what will you expect in the FeV1 ratio? It is decreased. And what is RV? Residual volume. What kind of impact you will expect in this case? What is residual volume? The volume of air which remains in the lungs even after forced breathing. So it will not take part its role in the respiration. The main function of the residual volume is to prevent the collapse of the lungs. The lung is being prevented from the collapse by various factors. Among that, one of the factor is this residual volume. And how will you measure the residual volume? Is it possible to measure by spirometry? Nitrogen washout method. And there is also one more method where you can do it is helium dilution technique. You just note it down in the residual volume, lung volumes, helium dilution technique or helium dilution method. Okay. The person is experiencing in a chronic state. It is not 1 or 2 days defect. He is having, whenever he is doing exertion, he is experiencing difficulty in breathing for a longer duration of time. Okay. Okay, clear? So we will move on. The next concept is dead space. So the term dead space, with respect to the respiration, if you say it as a dead space, means it is not involved in the gas exchange. The space which is present in the lungs, which is not involved in the gas exchange. So this dead space, you can categorize this dead space is into anatomical dead space, alveolar dead space and physiological dead space. What is meant by anatomical dead space is that is in the respiratory system. Okay, we have already seen the tracheobronchial divisions, conducting zone, respiratory zone. What is conducting zone? Where there is no alveoli. Only in the respiratory zone you are having the alveoli. And from the nose, so from the nose till the 16th division of the tracheobronchial division in the respiratory tract structures, the nose, pharynx, larynx, then trachea, tracheobronchial division up to the 16th division. That is anatomical structure which is involved in the respiratory system where no gas exchange takes place. So that is called as anatomical dead space. Anatomically, because there is no presence of alveoli. Wherever you have alveoli, only in those regions gas exchange is taking place. Okay. And what is meant by alveolar dead space? We have just now seen the alveoli is the place where the gas exchange is taking place. But now alveolar dead space is coming. So what is meant by this alveolar dead space is even in the respiratory zone, there are alveoli. But if those alveoli is lacking the blood supply, exchange is going to take place between the alveoli and the blood vessels, right? But if the alveoli is lacking the blood supply, if there is no blood vessel to the particular alveoli, it cannot participate in the gas exchange, right? So they are called as alveolar dead space. And altogether, combination of anatomical dead space and alveolar dead space, you will term it as physiological dead space. Okay, clear? So that is what is the three types of dead space. Respiratory pressure, we have already seen. Okay, clear? And what is meant by Boyle's law? Anyone? What is meant by Boyle's law? So the pressure which is present in the gas, it is going to be inversely proportional to the volume of the container. So that is the termination of the Boyle's law. So the pressure which is present inside the container, it is inversely proportional to the volume of the container. So if you want to define Boyle's law, that is the pressure of a gas which is inversely proportional to the volume of the container. So based upon this, we are going to make the respiratory pressures. So the respiratory pressures, we have 4 different type of pressures, and the first one is anatomical pressure. Sorry, the atmospheric pressure. Okay, so what is meant by atmospheric pressure? Why we are bringing this atmospheric pressure into the respiratory system is because as how what we have seen in the cardiovascular system, the blood is always moving from high pressure to the low pressure zone in the cardiac cycle. Yes, sometimes it will be from the atrium to the ventricle, ventricle to the aorta, and again venous system to the atrium. It is in a cyclic way. The pressure zone is different, but high pressure to the low pressure zone. That is how the blood is always moving. In the same way, this gas exchange is also going to happen based upon high pressure area to the low pressure area. Okay, and the respiration is process involved with inspiration and expiration. That is the 2 basic events which is happening in the respiration. And in the respiration, you have 2 basic types. In external respiration and internal respiration. Okay, so respiration you have 2 categories, inspiration and expiration. In both this, you have external respiration and internal respiration. So what is meant by this external respiration is, first, you consider the lungs, okay, and it is supplied by the blood vessels. So now the air is going to move from the atmosphere, right? It's not selected. So the air is going to move from the atmosphere into the lungs. Yes or no? So that is called as external respiration. And once when it has reaches the alveoli of the lungs, up to that there is no gas exchange. That is called external respiration. Then from the alveoli into the blood vessels, and this blood vessel is going to supply the oxygen to the cells. So alveoli movement, the gas movement from the alveoli into the blood vessels, and from the blood vessels into the level of the cells. It is called as internal respiration. So initially the air is moving from the atmosphere. So you have to consider the atmospheric pressure. Atmospheric pressure should be higher than that of the alveolar pressure. Then only the air will move from the high pressure to the low pressure zone. Okay, so based on this, we are going to see the respiratory pressures. You know what is intrapulmonary pressure. You know what is intrapleural pressure, which is also called as intrathoracic pressure. We have seen explanation about this since morning. Yes, clear? And transmural pressure, it is nothing but the difference between the inside and the outside pressure. That is the difference between the alveolar pressure and the pleural pressure. That is transmural pressure. And now we will see the graphical representation of this intrapleural pressure. If you understand this, you will understand the mechanics of breathing. So in the mechanics of breathing, we will be seeing the pressure which is involved in the breathing. It makes the air to move from one zone to the another zone. And second thing, we are going to see how the muscles of respiration is involved. Okay, so first in the respiratory pressures of intrapleural pressure, we have seen this intrapleural pressure will always remain negative, whether it is inspiration or expiration. So this is the graphical representation you will get if you record the intrapleural pressure. Okay, so now consider this is the resting state. What is the value of the intrapleural pressure during resting state? Minus 2.5, negative pressure. I said it is always negative, so it is exerting a suction force. And in case of lungs, it is making the lungs to move towards the thoracic cavity, outside pressure, okay, which is preventing the lungs from the collapse. Clear? So this minus 2.5 of intrapleural pressure, that is the pressure outside the lungs. What it is going to happen when you are doing the inspiration process? When you are doing the inspiration process, the lungs expands. Yes or no? In order to make the air to fill inside the lungs, there is expansion of the lungs. So what happens? More and more of intrathoracic pressure is becoming negative. So during inspiration, what will happen is the graph moves downwards. From minus 2.5, it becomes minus 6. Okay, here this is the pressure in relation to the outside of the lungs. Okay, and after that, followed by inspiration, you will have expiration. So expiration, the air is moving out of the lungs. Again, the intrapleural pressure goes back to its normal level. So this is how the intrapleural pressure is maintaining its negativity. And how this intrapleural pressure is maintaining its negativity is because the pleural fluid, it is continuously drained by the lymphatics. The pleural fluid is secreted by the pleural cells, and after the secretion it has to be drained, as like how we are having the CSF drainage from the arachnoid villi. It has to be drained. The lymphatics which is present over here, it is draining the intrapleural fluid, so that is exerting a negative pressure, which makes the pressure value to be maintained always in its negative. That is the basis behind the negativity of the intrapleural pressure. Okay, clear? And now moving on to the intrapulmonary pressure. This is going to tell you how the air is moving from the atmosphere into the lungs. Okay, so now this intrapulmonary pressure, it is the pressure inside the lungs. Okay, so now consider the intrapulmonary pressure inside the lungs at the beginning of inspiration, that is at the resting state. 760 mmHg. What is this 760 mmHg? It is the atmospheric pressure, normal atmospheric pressure at the sea level. What we are surviving now, that is the sea level. Okay, if you go into the deep sea diving, or if you climb the mountain, the pressure increases, decreases in high altitudes or in deep sea diving. So the normal atmospheric pressure, what we have measured, and it is the standard pressure 760 mmHg. Since it is the sea level, it is also called as zero level. Okay, so now the atmospheric pressure is 0. The air at the beginning of respiration should move from atmosphere into the lungs. Now the atmospheric pressure is 0. If the air has to move from atmosphere into the lungs, the lung pressure should be minus 0. Next you have -1, -2, and higher value is +1. So atmospheric pressure is 0. It is standard. We cannot change the atmospheric pressure, right? So the lungs should have -1 as its pressure in order to make the air to move from atmosphere into the lungs. How it is happening is at the beginning of inspiration. What is the condition is 0 level. Once when the air goes inside the lungs, the intra-alveolar pressure will become -1. Okay, so this makes more and more amount of air to move into the lungs. So once when the air is filling in the alveoli, the pressure increases because it is filled with the air. So that increases the alveolar pressure at the beginning of expiration. So at the beginning of expiration, that is positive pressure. So what happens? Atmospheric pressure is 0 and this is +1. So from +1 to 0 level, air will move out. So this +1 and -1 variation in the intra-alveolar region makes the inspiration and expiration to happen in a rhythmic way. Okay, so this is beginning of inspiration, at the end of inspiration, then expiration is going to take place. At the beginning of expiration, again the cycle continues. So that is why we are getting the graphical representation of tidal volume like this, because the intrapulmonary pressure is giving its alternation of +1 and -1, which makes the air to move from high pressure to the low pressure zone. So these respiratory pressures, they are all very, very dry topic. But once if you understand, you can easily understand the mechanics of breathing. Okay, clear?